This is Rob Finkelstein from Center for Skin Wellness, and this is...
I'm Michelle Isaacs. I'm the nurse practitioner here.
And this month is Melanoma Awareness Month, and today we're going to be speaking about melanoma and skin cancers, and we're going to get some questions from our live audience and from the Facebook audience and talk about skin cancers in general and any questions that anyone has regarding melanomas and skin cancers. We'll try to answer any questions that you guys have in case you can't get into the office and you had some questions about skin cancer. Go ahead, and this is your time.
Any questions?
Let's see a question from the audience.
Okay, how can we tell the difference between melanoma and other forms of skin cancer?
I will answer that. Okay, we'll kind of alternate. So the question was, how can you tell the difference between melanoma and other types of skin cancer? So I'll kind of briefly go through like the major types of skin cancers. Melanoma is one that most people hear about, but it is not the most common one. The most common skin cancer are basal cell carcinomas, and the next most common is something called a squamous cell carcinoma. And those are by far the most common that we see. The difference between them and melanomas are usually moles. They're pigmented growths that usually look abnormal. Their colors are abnormal, their shapes are abnormal, whereas basal cell carcinomas and squamous cell carcinomas are generally sores that don't heal. That's kind of what I tell people. Like I said, that rule of thumb is that if you have a sore, it's usually on a sun-exposed area that doesn't heal. That looks most likely like a basal cell carcinoma or squamous cell. Whereas melanomas may be on sun-exposed areas, but they may not be on sun-exposed areas, and they're generally moles that look irregular.
Good answer.
Next question.
What are the different treatments for melanoma?
So I'll go into some of that and then you can ad-lib.
Sure.
So typically when a patient comes into the office and we suspect that they have a melanoma, we start with a biopsy first. Typically that would be a shave biopsy. And then once it's confirmed, then depending on how deep the melanoma is, it's typically what we go by. There are different guidelines that we follow for whether we do a wide excision, where we kind of make like a football or diamond shape around the lesion and remove more skin, which involves sutures, and we close it together. Or if there's a little bit more involvement with the melanoma when we get a report back, then sometimes we refer patients out to, good.
We're just
Okay,
turn the
we keep
volume up,
talking.
or you can talk a little bit
Then we
louder.
may refer them out to another center such as Moffitt Cancer Center if they need to have a lymph node biopsied with it, or more in-depth care for the melanoma. But typically if it's something that we biopsy and it's not too thick, it's a thinner melanoma, we can take care of it in the office and then bring you back for more frequent skin exams to stay on top of it.
One of the newer kind of interesting things that we're doing also, because a lot of people come in with moles, we're not sure whether they're that irregular that we want to biopsy it, or they have so many moles that it's a biopsy. All of them just would be, we don't want them to look like Swiss cheese. So there's a gene expression test called DermTech, where we put these stickers on a mole, and we basically peel the stickers off, and we get cells off of those moles, and we send, there are 4 different stickers, and we send the stickers to a lab in California, and they can actually tell us by gene expression whether they express melanoma genes. And if they do, then we can go ahead and biopsy them. If they don't, we have a pretty good idea that they're benign, and that way we don't have to do a lot of biopsying. So that's kind of a newer technique that we have.
The question is online, how often should we have skin exams?
Okay. So it kind of varies for everyone. If you're a patient who doesn't have any skin cancer history for yourself or a strong family history, then at least once a year is what we recommend. If you've had a skin cancer history of a melanoma, then we bring you back in increments of every 3 months, then 6 months, then we go back to 1 year if your melanoma then there are other patients who have non-melanoma skin cancers that Dr. Rob spoke about, either a basal cell, a squamous cell, or they may even have precancerous lesions that we call actinic keratoses. And then depending on what's going on and what type of treatments we're doing for those patients, we also bring them back a little bit sooner than a year or two. But it's also important just to do due diligence to yourself and check. So if you ever see something, every time I tell a patient, I'll see you back in a year, but keep an eye on your skin, and if you see something that's concerning and it's changing, then come in sooner. Don't wait.
What are some characteristics if you're concerned about melanoma that you can look for?
You can repeat the question, please.
So the question was, what are some of the characteristics that you can look for if you're looking for a melanoma? That's a good question. So generally, the rule of thumb, or the rules of I always say rule of thumb.
We said rule of thumb like 10 times in our last
We did. I just
Facebook Live. Okay, keep going.
Rule of thumb. So the rule of thumb is what we call A, B, C, D, and I like to say E. So A is asymmetry. So you want a mole to be symmetrical. If you cut a line down the middle of it, you want it to have equal parts. B is border. You want the border to be nice and clear from the regular skin. You don't want the borders to be fuzzy. Color is C. You want the color to be uniform, usually uniform brown. You don't want to see dark brown, black, red, brown. That's what we call variation or variegated color. And D, the rule of thumb, is you want them to be the size of a pencil eraser or less, or about 6 millimeters. These are all kind of standard rules, but it's not always like that, but that's what we tell our patients. E is evolve. So if you have a patient that has a mole that's been changing over the last weeks or months or even a year, then that's also a sign that it may be a melanoma. Basically, any changes in size, shape, and color is what you want to look for in a melanoma.
Is there a relationship between the three types of skin cancer? If you have one, do you have to be concerned that you will have the others?
Not necessarily. Sometimes, I'm sorry, I'll repeat the question. So the question was, if you have one type of skin cancer that you get diagnosed with, are you more susceptible to having the others? For melanomas, I don't really believe there's a strong correlation between basal and squamous cells and melanomas, because they can be sun-related, but I'm going to let you kind of jump in with that one.
I think that it's not like one becomes another. So they're different cancers. It's not like a basal cell can become a melanoma or a squamous cell can become a melanoma, first of all. But what Michelle was saying, that there is usually a genetic predisposition, fair skin, light eyes, family history of all those different types of skin cancer. So one member of the family could have a history of squamous cell carcinoma, another could have basal cell, another could have melanoma. So there's definitely a genetic predisposition to get all three skin cancers. So whether it's within the family or an individual, if you have one skin cancer, you are more prone or predisposed to getting another.
But just because you have a basal cell or squamous cell doesn't mean that you're destined to get a melanoma either. But that's the importance of coming in to get checked. Anything else?
What about skin cancer prevention? What can we do to prevent it, and like as far as sunscreen, and what should we look for in a sunscreen? How much should we use?
Okay. We'll both kind of answer this one too. So in regards to sunscreen, I think the biggest thing that I tell patients that I see is to make sure that it's a broad spectrum sunscreen, so meaning that it's protecting against UVA and UVB rays. There's different controversy with sunscreens, whether you use something called a physical blocker, or sometimes they're referred to as mineral sunscreens versus chemical sunscreens, which can both be broad spectrum and cover both rays. So I think without getting too, going down a different path with that, it's really up to you. So I always tell patients, if you prefer just to use a chemical sunscreen, which are ingredients that you're gonna find avobenzene, oxybenzone, then you can use those. Or if you're like, I really just wanna use something more natural, and you can stick to the physical blockers like titanium dioxide as well. So, or zinc oxide, those are like the two physicals. The big thing with those, both of them are reapplying. So making sure that if you're outside, if you're sweating, if you're in the water, that you're reapplying more frequently. And then an SPF of 30 is typically rule of thumb, what we recommend or what I've heard you
Yeah.
recommend and I recommend also. And then in regards to the amount, I always tell patients, if you heard our last Facebook Live, I kind of mentioned this too, at least 1 ounce of sunscreen, which is a shot glass or a golf ball size for the entire body. And that's what you should be reapplying. So sometimes I'll hear friends or family members at the beach or the pool who are like, oh, I've had this sunscreen for a year or 2 years, and it's like a 4 ounce bottle. So if you go by those rules, then you should be done with that bottle pretty much 1 day out at the beach. So really, I think the big factor that a lot of people miss is the reapplication of sunscreen, which goes a long way. What was that?
One of the questions online was, I had a bad summer when I was a kid, am I at risk for skin cancer?
Oh, well, that's kind of what I was going to say anyway, as far as the follow-up question. So prevention. I mean, the big prevention is when we're younger, we get most of our sun. So most of our sun is in our preteen years, and especially our teenage years, when we all like having that tan, that base tan. Most of our sun is before we're 20. So as parents, it's important to instill into our kids the importance of protection. I mean, we need to have some sun. They need some ultraviolet light to convert their vitamin D and for calcium reabsorption. So we won't want to say that you can't have sun at all, but you don't want to get sunburns. We know that acute sunburns that you get that are real bad, like sun
Blistering.
poisoning, blistering, can set you up for skin cancers, especially melanomas when you get to be my age. So prevention is really the way to go. If you can prevent those bad burns and chronic sunburns and avoid tanning salons, they're evil. That might be controversial, but to me it's not. Then you can prevent skin cancers at a later age. And so your question was about the bad sunburns when you're younger. Yes, again, it depends on the genetics, depends on how many sunburns, how severe, but that can set you up for skin cancers, especially melanoma when you get older.
How early in someone's life can they get melanoma?
Across the spectrum. Really, you can have pediatric melanomas, which are obviously more rare, but we do see them. So again, if you have a child who has a suspicious mole, it's good to get them in just at least to get a baseline, and you can see it all the way through the elderly. So it doesn't really discriminate necessarily because we see them across the lifespan.
Yeah, melanomas can be very tricky. They can be born with melanomas, unfortunately. Melanomas can be, they're not, like I said, they're not sun-induced always. You can have melanoma in the eye. You can have melanomas under the foot, in between the toes. Bob Marley died of a melanoma under his foot. You can have melanoma in the scalp, in the genitalia. So it's not, most people think, well, I avoid the sun, I'm not gonna get a melanoma. It's not always sun-induced. Yeah, that's why it's important to get a full skin exam, your birthday suit, and look in the scalp, look under the feet, look at the hands, in the nails. You can get melanoma under the nail, and that can be devastating because it often gets overlooked. Next question.
How quickly can it spread and how dangerous, how quickly do you have to react?
To melanoma specifically, so kind of going back, okay, I'll repeat it. So the question was, how quickly can a melanoma spread, or how worried do you have to be about it? So that kind of goes back to the previous question. We were talking about diagnosing a melanoma. Depending on that initial biopsy or excision, when you remove the melanoma, you find out the depth of it. So from there, you look at different levels within the biopsy or the pathology report, and that gives us a better idea of how invasive the melanoma is. So if there's any lymph node involvement or any spread throughout the body, which would happen after you do the biopsy, or you would find that information out after the biopsy, then you would know. You can't really tell by looking at a melanoma or doing an exam how bad or how good it may be. So it's really dependent on the person, on how long it's been there, how deep it is, if there's any spread to other organs, anything else.
No, I think that was good. The main thing I think is if you catch a melanoma early, it's curable, 100% curable. If you catch it too late and it spreads, it's deadly. It's still one of it's the most curable disease, but also can be one of the most deadly diseases. And that's why it's really important to get screened. It's a detectable, easy curable thing if you get it in time. If you don't, and again, it depends on the person, their age, their immune system. It could spread quickly. But if you catch it early, all you need is to cut it out, and you don't need chemo, you don't need any radiation. That's the end of it. But once it spreads, it's very difficult to treat.
When you say cut it out, what specifically do you mean by that?
So the question was, when we say cut it out, what does that mean? It really depends. Removing it depends on how deep the lesion is. Melanomas always go by depth. So the more superficial, the less you have to cut out. The deeper, the more you have to cut out. And there's guidelines that we have that we won't get into the details of it, but there's guidelines that the American Cancer Society has as pertains to the depth of the lesion. If they're real superficial, you need a smaller margin, but you always want to get a normal margin. And generally, mostly what we do is we cut it out like Michelle does, like a football shape or saucer, and we remove it and put stitches on the inside and the outside. When they get more advanced, sometimes we have to refer it. So there's a question about Mohs surgery.
Oh, okay.
And Mohs surgery is a specialized surgery that we do. They're usually specialist dermatologists, generally that treat skin cancers, mostly basal cell carcinomas and squamous cell carcinomas of the head and neck, and more difficult areas like the hands or lower legs, where you take the lesion out at the time of the visit in stages. You cut out what you see. The actual dermatologist is also a pathologist, and they look at it under the microscope to see if there's any bad cells. If there are, they go back and cut more out, and they keep cutting it out until they know that it's gone. They look at it under the microscope, and when they know it's gone, during that same visit, then they repair it, and that's called Mohs, M-O-H-S surgery. And so it's a specialized skin cancer surgery, and we do that here at the office at the Center for Skin Wellness.
Yes.
So, about 3 years back, my father was diagnosed from a different dermatologist with 3 melanomas, and they were on his face. And we were referred to a plastic surgeon to have them removed. So when does a dermatologist remove them, and when do you have to go on to see a plastic surgeon?
So sometimes that depends if, like on the face being a more cosmetically sensitive area, depending on the experience and how comfortable the dermatologist is with their skills or how they think the patient's going to heal, they can kind of, sorry, I need water, they can kind of gauge it and decide whether or not, I don't like to share, whether or not they feel comfortable. So for instance, when we do removals here for various lesions, whether it's melanoma, basal cell, squamous cell, like I will not touch anything on a patient's face, but I remove things on the arms, the chest, the back. Dr. Rob will sometimes do things on the scalp or the face, but then that's where it gets into the areas where when they're more difficult or sensitive, and depending on other things that's going on with the patient, they may want to have a Mohs surgeon. And sometimes Mohs surgeons also work with plastic surgeons to do closures that they specialize in. So it really depends on the location, the size, the involvement, what's going on. It's It's not always like a one-size-fits-all answer.
Yeah, we kind of like to work with
Mhm.
the plastic surgeons like as a team and work with the patients and the patient's family and decide what's the best for them. Yeah. Any other
Anything
questions?
If someone's concerned they might have skin cancer, what's the next step?
If they're concerned that they have skin cancer,
Mhm.
make an appointment with one of us. The best thing is basically just getting in. I think it's definitely better to be safe than sorry. So sometimes we have patients who come in and they're like, oh, I feel so silly. I came in for this. It was nothing. And I always tell patients, never feel silly. It's better that you're being proactive and you're coming in, because sometimes you don't know, you don't have a trained eye, and there are some things that you may think are nothing and we're more concerned about. So it's always better to come in and get it assessed, and if it's nothing, then great, and if it's something, then we'll take care of it.
Yeah. I'd say
That's my answer.
here, no, that's a great answer. In Florida, we kind of, dermatology offices act as like primary care, just because it's so hot and sunny and everybody has a lot of sun exposure. So, having yearly visits, I would say over the age of 50, depending on how much sun damage you've had, sometimes earlier, is a good thing to do. Now, if you suspect that you have a lesion, get in. That's the best way. What's great about dermatology is we don't have to do any probing or we don't have to do invasive testing. What we see, we can easily biopsy it. We just numb it up and biopsy. It takes 5 minutes if we think that you need to do it. So it's a real simple procedure. No one needs to be afraid of it. It's easier than dentist.
How soon can someone get an appointment?
So I'm like looking at our office manager, I'm like, well, how soon?
Julia?
If a patient calls and they have a concern that they're like emergently concerned about, then we can usually get them in that day, if not that week. So if it's a routine screening, it really just depends on your schedule. The girls at the front do a great job communicating with patients or potential patients to get them in and fit their schedule. We also offer extended hours, so we are open until 7 p.m. on Wednesdays. I'm here seeing patients. So if you work, if you have kids, then you're more than welcome to come in later. And then we also open earlier on Friday mornings around 7:15 to get you in before work or school too. So very convenient.
Do you see children?
We do. We both do.
We do see children, all ages. Yeah, all ages. Well, I think that's going to wrap it up. I just want to thank everybody for joining us for Skin Cancer Awareness, Melanoma Awareness Month. Thank you, Michelle.
Yes, thank
And
you,
thank you,
Dr.
all
Rod.
you guys
Thank you,
for coming
everyone.
out. Appreciate it.